If anyone's like me, I'm gonna give them till 12:01 to join. And then we'll continue on with our introductions. Super excited to see some of my colleagues from Moxie and Proxy here. That's the Michigan Oncology Quality Consortium and the Patient Oncology Quality Consortium. Our colleagues from MDHHS, YesRx. Thank you for joining us today. Friends from Corewell Health, Rogel Cancer Center. Okay, welcome to the April 2025 session for the Hope Learning Collaborative. As you join, if you haven't had the opportunity yet, I just want to remind everyone that spring is a time of rebirth, renewal, and a time to recharge, marked by nature's awakening and the flow of life. And we witness this in the melting snow and the sap flowing. Please feel free to introduce yourself and share what you would like to renew in this coming spring. Again, thank you for joining the April 2025 Healing Oncology Partnerships for Equity, Hope, and Research Learning Collaborative. I have a few acknowledgements and disclaimers. This training series is funded through a Patient-Centered Outcomes Research Institute PCORI Engagement Award, number EACB 34437. The views, statements, and opinions presented in this cultural training series are solely the responsibility of the author and not necessarily represent the views of the Patient-Centered Outcomes Research Institute, its boards, or of governors or methodology committee. If you're just joining, please feel free to introduce yourself in the chat. I have a big ask for today. As you know, part of being the recipient of award comes evaluation. And we have an evaluation requirement for this project. And so we hope that you will answer the pre and post survey questions. Catherine's going to put the poll up now. The post survey questions will be posted at about 12:40, 12:45. So please feel free to answer the post survey questions as we're doing some Q&A with Melissa. We just want to ensure that everyone's view is heard and that make sure that we are presenting this information appropriately for everyone. Well, I'm really super excited today to introduce my friend and colleague, Melissa Buffalo. My name is Beth Seeloff, and I'm the co-lead for the Hope Project and a public health specialist dedicated to serving tribal communities across the nation and most importantly, the state of Michigan. I'm very honored to introduce my friend, a strategist and confidant, Melissa Buffalo, who is a citizen of the Muscogee Nation. Melissa has nearly 20 years of experiencing advancing public health and equity for Native communities. As CEO of the American Indian Cancer Foundation, she leads efforts to reduce cancer disparities and improve outcomes for tribal nations and Native communities nationwide. Under her leadership, ACAF has expanded culturally tailored cancer prevention programs, strengthened tribal partnerships, and raised national awareness of Indigenous health inequities. Melissa's advocacy extends through her service on various boards and committees where she amplifies Indigenous voices and champions better standards of care. Melissa, thank you so very much for joining us today. And I'll hand it over to you.
You, Beth, for that beautiful introduction. As we pull up the slides, somebody's going to share them for me because we are having, I think, what I call Melissa difficulties. So it'll be easier if somebody else shares them. Um, Ampetu Washte, Melissa Buffalo, Imachi Apie, Michincha Nu Myunke, Kanji Wakba, Oyanke Na, Meskwaki, He Matahan. Good afternoon, everyone. I let you know my name. I let you know that I'm a mother of two. I am a citizen of the Meskwaki Nation. I'm also Dakota from the Crow Creek and Lower Bill Sioux tribes in South Dakota, where I was born and raised. And I just want to also participate in, that reawakening. And I was looking at everyone's beautiful comments, and I think mine is to reawaken my love to jog. It's been a while, and as you get older, your knees are not as strong as they used to be. Um, I also want to share that the American Indian Cancer Foundation is located on the traditional lands of the Dakota people in Bede Ota Otunwe, Minnesota, or the present day city of Minneapolis. Super excited to be here, and I want to thank Corewell Health for allowing me to share my experience, my time, and expertise in this space with you all today. I also want to thank Beth for making this connection for us. Beth is also somebody I go to a lot when we have questions when working with tribal clinics. So she is also an expert in this field as well. Excited to talk about American Indian cancer disparities and the impact of historical trauma and colonialism with you all today. Next slide. And again, love the name of this series, Healing Oncology Partnerships in Equity, Hope, and Research. I think that truly resonates with the work that we are doing here at ACAF. Um, as I mentioned, as a Meskwaki Dakota mom, I'm a mom, a sister, a daughter, a friend, and community member. My family is what keeps me grounded and guides me every day in the decisions I make to lead this wonderful organization that I am very personally and professionally committed to doing. In our culture, as Native people, we understand that our well-being is interconnected and that when one of us is hurting, we all feel it. And I think that's especially true when it comes to cancer, because this is the disease that has deeply affected my own family and so many of our Native communities. I lost my mom to cancer just as I became a mom, and that grief never fully goes away. We know that grief can show up in quiet moments and big milestones, and in the work that I do and that we do every day. I think about her strength and resilience, and how much I lean on that to continue to inspire me. I think she truly taught me what it means to care deeply, to lead with love, and to, again, just push for better care and access for our people. As a mother myself, I think about the world that I want my children to grow up in and everyone that they will be working with and living with and coexisting with. We want a world where Native lives and stories are valued, where access to healthcare is a standard, and where our traditions are part of that healing. And as I said, leading this work isn't just professional, it's deeply personal. Every initiative, every partnership, every program is truly rooted in the love that we all have for our communities and the hope that we can change this story for the next generation, and why we show up to work every day, especially now more than ever as we think about public health as a nation. I think because we know we all deserve better, especially Native people, as somebody who's been impacted. Our families deserve better, and I think together we can create a future where cancer no longer takes our loved ones before they should. Next slide. Again, just, wanted to quickly go over the learning objectives for today, understanding historical trauma and colonization. And so hoping to give you a very brief overview of some of the events and policies that, have contributed to historical trauma, forced assimilation, boarding schools, some of the government policies, and again, just understanding that loss of cultural identity and how that impacts health today. How can we identify those health inequities and address them in a way that is culturally sound? And so when we look at some of those, again, understanding, what are the current numbers as best we can assess for cancer incidence and mortality, and again, how various traumas and colonization has contributed to these inequities. We'll talk about the limited access to healthcare, socioeconomic challenges faced by our Native people, and again, what are some of those cultural barriers that are impacting health? Third, I'll talk about advocating for policy and systemic change, wanting to discuss with you all the importance of policies that can help support cancer prevention, early detection, and again, how we can ensure that there are treatment options for American Indian and Alaska Natives, because oftentimes they are diagnosed at later stages. Like I said, my mom passed when I had my son, and her cancer hit, and within 3 months she was gone. So I definitely can understand the importance of change and policy. I want to close with, understanding and promoting cultural competence and what that means. We use a lot of words, right? Cultural respect, well, it resonates. And so again, what are some tools and resources that we use at the American Indian Cancer Foundation to promote cancer prevention, screening, and wellness that is grounded in all of the tribes that we serve, and how we can work to help systems and providers understand and build trust with the patients that come through their doors, so we can all work together to reduce those cancer burdens. Next slide. Just quickly, the American Indian Cancer Foundation is a national nonprofit that was established in 2009 to address the tremendous cancer inequities faced by American Indian and Alaska Natives. Our mission is to eliminate the cancer burdens of American Indian families through education and improved access to prevention, early detection, treatment, and survivor support. Next slide. Our vision, and I think this is something that truly resonates with so many of us. We really do hope to see a world where cancer is no longer the leading cause of death for American Indian, Alaska Natives, but also for all of us on this call. Next slide. And the approach that we use here at ACAF, which we call for short, we love our acronyms. We believe that our Native communities, our tribal nations, have the wisdom and have that knowledge and history to find those solutions to some of these existing health inequities, but oftentimes, seek some of that organizational capacity, expert input, and some of the resources. So, we work and meet communities where they're at and when they, are looking for support. And I think that just helps to build a better end result when we have communities that are in a place and what their readiness is. And so truly coming from that approach just makes for a better outcome, I believe. Next slide. Again, just that first objective, understanding historical trauma and colonization. Next slide. I have to share, a couple weeks ago, I went to DC and I only had 15 minutes to give this conversation I'm talking about today. So I was like, here is a briefest timeline of 500 years that I'm going to try my best to do in 2 minutes. I don't know if that's something you could call success, but pulled some of that information here. And I won't go into everything, but again, just kind of wanted to give like a brief understanding, and just want to give note that some of this is heavy for some of us on this call, and to, do your best to take care of yourself during and after this presentation, because some of this information can hit a little close to home. And I want to make sure that, things that I share are not offensive in any way when we think about some of the impacts that have happened to our family and our ancestors. And so, we talk about, 1492, we talk about that early contact and colonization, understanding that the first treaty was signed in 1778, and how we see those treaties today and whether or not how they impact our health. Again, just looking at the 1800s, looking at westward expansion from the east to the west. I've talked about how the Transcontinental Railroad was complete, and you'll see some of that timeline as we look at, and, I encourage all of you to dig a little deeper to understand this historical trauma and this colonization and where our Native people are. There are 574 tribal nations today, and all of them come with their different and own experiences, history. And so how do we look at all of this from a lens of health equity? We can think about the land loss and that access to food and hunting, the Indian Appropriation Act, understanding the impact that the residential boarding schools has had on so many of us today. I'm in my mid-40s and have an auntie who, ran away twice from her boarding school, and finally her older sister, after my grandparents passed, was like, well, she's not going to stay, she can just be raised at home. And so that, is very close to home when we think about that impact, even though we look at it's in the 1800s, boarding schools operated up until the late 1900s. In the early 1900s, we had the Snyder Act, which was essentially the creation of the Indian Health Service, which again is the promise the government made in terms of giving up land and water and access to fish and hunt, and that our healthcare would be taken care of by the government. And again, IHS is one of the lowest funded government agencies. And scary to know where it could be in a couple years, but right now we'll just kind of go with where we're at. American Indians were not considered citizens until the late 1900s. Again, we're continuing that boarding school era. We think about those termination and relocation policies in the early 1900s. A lot of American Indians, Alaska Natives were, encouraged to leave their reservation, the land that they were forced to live upon, and were promised this amazing life if they moved to urban areas. The government saw this as a way as less responsibility for taking care of the American Indians and all the treaties that were signed. But once they got this one-way bus ticket, the money ran out, the technical training they were promised was not there. So you'll see a lot of cities like Chicago, Detroit, Minneapolis, New York, Los Angeles, Denver, Chicago, Seattle that have large Native populations. Minneapolis has so many programmings and urban offices to support our urban relatives here in our Twin Cities. The Indian Child Welfare Act was enacted in the late 1900s, and this is something that still impacts our families today, where children are being removed from homes and placed with non-Native families. American Indians were not allowed to practice their culture until 1978. And so again, I think about that timeline and knowing that my parents and grandparents had to hide when they wanted to practice their ceremonies, to speak their language in public, or to even think about how they honor traditional tobacco, something that was not allowed 47 years ago. The community food program was introduced in the late 1960s, I believe. Again, this was an opportunity to see where food was coming into the reservation, but as we look at commodity food now, it was not the food that was healthy, that was, provided health and wellness. It was full of fat and carbs. And so how we see a lot of that food still being used today, because that is the means that American Indians, Alaska Natives have gotten used to. And you say that in a very cautiously way. And then I added a slide on the 2000s, which was not in the last presentation I gave, but we think about that formal apology that was given from the Bureau of Indian Affairs for all the hurt that has been caused over these years. When we think about the work that we do in this space, we talk about, right, what is the action to the words that we're saying? The last tribes to receive federal recognition were 6 tribes in Virginia. Prior to that was the Shinnecock Indian Nation, and they were working to receive federal recognition for 32 years. When tribes received that federal recognition, again, looking at some of the treaties that have been signed and the promises from government and the dollars that can come into a lot of these federally recognized tribes, some of the state tribes. The Dakota Access Pipeline protest happened in the late, I would say in the 2017. Again, this was something that I think brought a lot of people to North Dakota to protest the pipelines that were, put in on the Standing Rock Indian Reservation. I'll talk about the last one here in a little bit in more detail, but, the remains of 215 children were found on a residential boarding school, again, unmarked graves of 215 children. Next slide. Again, this is, as we go through all of this does not include everything. I do my best to try to highlight some points, but there are so many acts and policies that have been enacted that impact our health today as Native people. This slide here, again, the very first boarding school was implemented or created by Captain Richard Henry Pratt, and his focus of boarding schools was to kill the Indian and save the man, and thought if we can remove any connection they have to who they are as Native people, they can become members of society. And so I'm such a visual person. You'll see pictures on the internet if you just Google boarding schools and forced assimilation, and even that quote, you'll see before and after pictures of children who were forcibly removed from their home and taken miles away to various boarding schools across the US. We think about, right, like how much data was accurate back then. They have numbers about 6,000 within the first 15 years of boarding school, but we think about the numbers that weren't necessarily counted and what they were counted on. But you can see children's traditional clothing was removed. Their hair is no longer long. You can even see the posture that they're sitting in. And so just always encourage folks to take a look at some of these pictures and, just kind of sit with them as well and think about that impact on health. Next slide. Another slide that I think is really important to share as we think about the impact of boarding schools for our relatives, our grandparents, great grandparents. It essentially was education for extinction, and it was considered assimilation through total immersion. And I always like to encourage people to not use school because they were not schools. When we think of schools, one of my mentors said, when we think of a playground on a schoolyard, that's what we think of, right? A school with a playground, not a schoolyard with unmarked graves. And then I also look at this photo too. As I mentioned, I have two kiddos. I have a 13 and a 14-year-old. My 13-year-old son has ADHD, is on the spectrum. And I look at trying to get not only my child, but imagine, all these other children to stand this straight and all the same, like, right, they're all just holding what they're holding in a perfect line, perfectly, no movement. I don't know if we could even do that with a room full of adults, but yet the fear that was instilled in a lot of these children to be able to stand for a photo like this, all in the same clothing. And we think about school again, these were places where children were, again, forcibly removed. Their hair was cut. They were given uniforms that was something that was completely brand new for them. They were not allowed to use their names. They were given English names. They could no longer speak their language. They were often beat. If they did speak their language, they were expected to attend and understand Christian values and spirituality. Um, Again, schools is where we should feel a place of learning and education, but these institutions were places of chores and stiff punishments. A lot of people who did survive the boarding schools were sexually abused, physically abused, and carried that trauma with them for a really long time. A lot of them probably never spoke verbally about that experience. And so we think about that unhealed grief that many people carry, and then those traumas that become cycles through generations. Next slide. Kind of switching gears because I realize these two next two. Can you go forward one slide and then we'll come back to this one? So just to share again, in Canada in 2021, so just 4 years ago, the remains of 215 Indigenous children were found at the site of the former Kamloops Indian Residential School in Canada. And again, it just revealed that devastating legacy of the residential system that children experienced. Again, this is similar both in the United States and Canada, children being removed from their families. And you think about those parents whose children were taken away, if that's all they knew was to be parents and their children were taken away and never came home and never even received notice that they passed away. And so we think about these findings and how much they underscore a shared history of colonial violence across our borders. And again, just thinking about how many generations now were stripped of identities and never returned home. And so this start of those remains being found started the opening of both the United States and Canada looking into residential lands and how many children's remains were found on most of these lands in unmarked graves. Again, and this is heavy because this is things that impact our aunties, our grandparents, and those ancestors that should have been in our lives, but are not. If you want to go back one slide now. This is a photo of the aftermath of the Wounded Knee Massacre that occurred in South Dakota in 1890. US soldiers from the 7th Cavalry killed an estimated 250 to 300 Lakota men, women, and children at the Wounded Knee Creek, which is located on the Pine Ridge Indian Reservation in South Dakota. And, you know, they always consider this one of the last Indian wars. And again, 1890 to me does not seem that long ago. And so even growing up in the 1800s, how we, you know, relate to that. And it seems so far removed, but it wasn't. But, you know, in that time, it was snowing and the ground was frozen. And so once the ground started to thaw, the government and the soldiers just essentially buried a mass grave to put all of those bodies in. And so there's a very spiritual sacred site in South Dakota that honors this incident and a lot of those family members and children that were, you know, murdered at this site. I mean, so something that's very personal as somebody growing up in South Dakota and that history and how it's told, and, you know, being able to have these stories moving forward so we can understand the healing. And also then, you know, again, what's that connection to some of the health inequities faced by Native people today? Next two slides. Um, Very brief again, hoping would love to go into more detail with some of the timeline and some of those um, experiences and moments in time that impacted Native people and kept it short so we can get through these next three objectives, which are, again, how can we identify those health inequities and how we can relate those back to some of those experiences? You know, how do we understand that past to heal our future? Um, and so when we think about Native people being able to achieve their full health potential, like how do we come from that lens of, you know, understanding historical trauma are today's inequities, you know, from forced relocation and land loss. You know, again, I had mentioned earlier that disrupted traditional food systems. Was that impact on the boarding school, generational trauma, language loss, mistrust in so many systems, systemic racism and poverty, forced sterilization. IHS in the late 1970s, or the government authorized IHS to sterilize women without their knowledge. And again, we think about the number of women they have on data was 3,200, but we have to know that number is a lot more. I have an auntie, my dad's auntie, and in our ways, our grandma was one of those individuals. We think again about also, you know, poor housing and the changing in housing that Native people had to transition to, as well as, you know, what limited education and access they had to become part of, you know, Western culture and adapt and be able to support their family. Next slide. Excuse me. Again, so just kind of continuing with some of those health disparities that are faced by Native people, and wanted to go into some of the data with all of you. We know that our Native people experience higher rates of chronic illness. We think about heart disease, diabetes, even, you know, mental health disorders compared to the general population. We know that cancer is the second leading cause of death among American Indian and Alaska Natives. Lung cancer incidence among American Indian and Alaska Native men in the Northern Plains is nearly double that than in non-Hispanic white men. American Indians have the highest incidence of any population for cancers of kidney, liver, lung, cervical, and colorectal. I must have took this one out, but colorectal cancer, Alaska Natives have the highest incidence of colorectal cancer in the world. And that is where over half of our federally recognized tribes/villages are located. We think about that, the ruralness, the impact of weather that, you know, doesn't allow them to easily make appointments and get to larger cities like Anchorage to get screened for colon cancer. And again, also thinking about their diet and how that has changed. Cardiovascular disease is the number one disease among American Indians. And again, American Indians often experience heart disease 10 years earlier than other populations. This one's always a shocker for me. I always think about, like, dang, how this again impacts me personally, that the life expectancy for American Indian Alaska Natives versus non-Hispanic white population is 65 to 76. I think the last time the US saw this low of a number was in the 1940s. And this is the reality that Native people face both in rural and urban communities. My mom was only 56 when she passed. And so I am, just like many other people, are losing our relatives way too early because of barriers and burdens and disparities. And, you know, what we are doing to help raise awareness so that I can see a life beyond 65 and that my kids can have me and their aunties and uncles around a lot longer, because as we get older, 65 is not very far away. Next slide. This table shows the rate ratio of cancer incidence between non-Hispanic white population and our Native population. And again, just shows it on a national level and on a regional level within the Northern Plains. And again, it shows that nationally, American Indian Alaska Native population is 2% more likely to get cancer than the white population. And nationally, in some cancer sites, the American Indian Alaska Native population has lower cases of incidence rates than in our white population, but often American Indians, Alaska Natives are diagnosed at a later stage. And again, that cancer rate is a little higher. American Indian Alaska Natives are 26% more likely to get cancer. Also thinking about the Northern Plains, have high burdens of colon and rectum, where 69% are more likely, and then lung is at 80%. And again, that personal connection, both my parents grew up smoking in our home. So I think about that impact for me personally, but also knowing, for them to be growing up in the 50s, 60s, and 70s, we're not allowed to access traditional tobacco. So, commercial tobacco was just something that was always around. Next slide. Um, Again, as we're, continuing with those health inequities and identifying them, how do we think about some of those contributing factors that, equal to some of those numbers I just talked about? Limited access to healthcare. We know that our access to healthcare is limited, whether we're using Indian Health Service, which oftentimes those referrals may take a little longer, but we know that we do have programs that help to get our people screened who may not be insured or underinsured. We know that distance to care is often hours away for a lot of our folks that live on reservations to get to appointments for screening, as a lot of our IHS clinics do not have on-site screening. So we'll see a lot of mobile units come through. And again, even there, we know that those are limited to be able to get folks in on those screening events when they have those units on site. What are some of those socioeconomic challenges faced by our relatives? We think again about transportation. How far do they have to travel? Do they have gas money? Do they have a reliable car? A lot of times we see our grandparents and aunties taking care of, other children, grandchildren. And again, I just think just that fear of cost. If they don't think they have the money to begin with, what is that lack of wanting to get screened for cancer? And then again, the last contributing factor are those cultural barriers. Being able to walk into a clinic and feel welcomed is huge, right? For anybody. What is that communication when we walk through the door? Are there opportunities for folks to speak in our tribal language? And what is that trust in providers to understand our history, things that we want to be asked. I always think about my dad, who was in the hospital a lot in his last 2 to 3 years, was always asked, like, what do you do for work versus, tell me about your family. Where do you come from? Those are things that just seem more comforting for Native people. Another cultural barrier is understanding that family members are a lot. So when we think about how many family members come into a patient's room is a lot. And I think even just that small change of inequity of not realizing why there's 15 people that want to visit this one relative. We think about how large our family systems are. And just small things like that can again contribute to health inequities. And this is a picture of one of our staff who was just at the White Earth Nations Health Fair to highlight colorectal cancer. Next slide. They always say that it's not a native PowerPoint if you don't put your own kids in it. So had to pull a picture last night when I was thinking about, what does it mean when we think about, how we can engage in an upstream approach, how we can achieve health equity. And so my kids are part of the Indigenous peoples task force here in the Twin Cities, and they get to do theater, they get to incorporate their college or their culture. And this is after their performance, after their a conference a couple years ago, and they got to design their own outfits, and my kiddos and another coworker's friend designed basketball jerseys. And what even image was on there. I think my son put a bear who's in the middle, and that's my daughter. And even the numbers that are important to them. And so for me, I think about that visual, right? How do we support positive social determinants of health? How do we, look at social and economic opportunities for our relatives? How do we increase access to healthy foods? And sacred medicines when we're thinking about care. What is that balanced health? What, which includes everything physical, mental, emotional, spiritual. How do we work to break those cycles of trauma? I grew up, when I talk about stories too, and I, give presentations, I like to, share a little bit about who I am and where I come from, which you've heard here. I grew up in an abusive home because my parents, not only smoked, but also drank. And once you get older and hear those stories of how addictions start, you see the unfortunate traumas that have been passed down through generations. My dad was the oldest of seven, and his dad would go on binges, and my grandma would make my dad, as the oldest, have to go get my dad. And so that torn relationship with both his mother and father um led him to drink. And so my dad had three daughters of his own, and none of us are heavy drinkers, and I am so thankful for that, in ways that we have access to our culture, whether it's through school or our community. So again, to see this picture means a lot to me. Thinking about those protective factors, how can we prevent ACEs, and how does that come into play when we think about cancer? What is that cultural connectedness? Again, just increasing access, knowledge, and understanding of the role that traditional tobacco plays, and highlighting that when we think about tobacco cessation or commercial tobacco cessation. Um, what are those indigenous determinants of health? What are the social and economic aspects that when we think about that, increase to access to healthy foods, healthcare, housing, clean water, even air, right? And how does that determine who we are as Native people, and that sense of belonging, resiliency, and again, just practicing healthy coping skills, and how do we nurture those relationships? And I think even normalizing the conversation of cancer and healthcare and prevention can help, us achieve that full health potential. And so just again, overall, how we can bring all of that into a balanced lifestyle, we can truly help to achieve that equity. Again, I always talk about health equity should not be a goal. It should be a standard that all of us have a right to. And so just kind of, oh, next slide. I apologize. Um, So to take all of that and bring it back to, how are we using all of this information, being able to advocate for policy and change for Native people? I think this is where a lot of the work that we do at ACAF, especially our prevention and policy team, has done some amazing work. Next slide. And so looking at, the importance of supportive efforts and policies in cancer prevention. I love that we come from this health in all policies approach. Again, how can we work with tribes to help them feel empowered to lead and design their screening programs or prevention programs when they're working with health departments, when they're getting federal funding? How can they use where they're at and their readiness and what data they have to be able to, see where they can make policies with that health in all policies approach and that lens? How do we increase access to culturally tailored screening and prevention programs? Are we incorporating tribal language? Are we promoting that integration of traditional healing along with Western medicine? And that could be something as simple as offering traditional tobacco to a relative, to a cancer patient. Being able to carry that traditional tobacco going into a screening is something that is even ceremony for a lot of people. And so being able to, see this here as sweetgrass and, how we burn our sage and our medicines and, smudge in a space that is comfortable when we're going into something that is possibly for the first time, such as a screening or, coming back for a diagnosis. Another policy that we really like to highlight is, the two tobacco ways. So again, how do we promote policies that, yes, ban commercial tobacco, but then they also come in a light that uplifts and educates the importance of traditional tobacco and how we're reclaiming it and strengthening it in our communities. Whether we see folks that carry these seeds, that have the ability to, plant them and grow them and help our communities see that tobacco can be everywhere, whether that's in the tribal admin buildings, in the community centers, in the schools, having a garden, seeing where we can put all of these as policies across our communities in different programmings and all of that, I think is something that has been done and that we have, resources for. One that I personally think, how do we go about it in a way that is healthy? We see a lot of our tribal casinos still allow smoking. We do have a resource that talks about being able to create a policy to bring that in so it's limiting that commercial tobacco. And I think that's always an important conversation, right? Because tribes have that sovereign authority to um, determine how their organizations and their businesses are run, but we also want to ensure that, what is that access to a space that is commercial tobacco free, but that allows for traditional tobacco as well. Next slide, I just wanted to go into a little more understanding and definition of what we mean when we say the two tobacco ways. And this is the Asema plant, or I mean, the Chanchasha plant that we have in South Dakota. I know we have it here in Minnesota as well. It's essentially the red willow. And you'll see in the bottom picture that that is the red willow in the bottom right, but that is the inside of the bark that we turn into shavings and it's dried, and that is what we consider our tobacco. And we know that traditional tobacco use honors the creator by cultural protocols for spiritual, ceremonial, and cultural uses. We know that it's a sacred medicine and that it carries its own spirit, right? It's almost like a relationship that we have with it, just as we have a relationship with our children, our friends. And so we see this as its own life, and something that is very important and sacred to so many of our tribal communities. And then when we think of commercial tobacco use, we know that it can cause sickness, disease, and has often led to an early death for many of our communities. We know that it's governed by marketing protocols of addiction. We know that many of our tribal communities, among other communities of color, have been targeted by companies to market and use their tobacco. We know that it is manufactured for recreational use and that it contains harmful chemicals linked to cancer, heart disease, and other illnesses. So again, understanding that traditional tobacco is in its raw, pure form and often is not smoked. We use it as an offering, something we carry with us. One thing that we're talking about here and planning for is in May to honor what many people know as World No Tobacco Day, but for us, that does not equal traditional tobacco. So coming from a place where we're keeping tobacco sacred, which is a common phrase a lot of us on this call have probably heard. So how can we take this day and, yes, not want to highlight commercial tobacco use, but to also praise and give strength and honor to traditional tobacco and the role that it plays in our communities. So that is something that we're working on, hoping to have some resources or information out. We also would love to partner with others on really highlighting the importance of traditional tobacco and reframing this day from World No Tobacco Day. Next slide. What I have, okay, I gotta finish up in 5 minutes, y'all. This is, again, this is a video that I took a screenshot of that is available on our YouTube. It is Dr. Anthony Stately from the Native American Community Clinic, the director who got interviewed through one of our research project and did a low dose CT scan. And so again, when we hear low dose CT scan, that can be a little intimidating. And so when we see some of those numbers I talked about lung cancer in our communities, especially here in the Northern Plains. How can we educate and bring awareness about some of these screenings and why we should do it? Especially lung cancer, we know for many communities there's stigma, but I don't feel that we experience that in Native communities because of those behavioral risk factors and those addictions to things such as smoking. Again, we want to highlight the importance of early detection and how we can frame those in policies. Here at ACAP, we have a screening policy that allows staff to not have to take personal time off to get screened for breast, colon, lung, and cervical cancer. We also give staff 2 hours a year to do an annual physical. So being able to remove that barrier and bring initiatives that really help to allow our working staff the opportunity to get screened. So how can we bring a lot of that to community-based screening programs? How we can use these programs to improve cancer outcomes, how we can work together to bridge gaps in screening, talking about that healthcare access, improving it, building trust, and also working with tribal clinics and communities that do, oftentimes receive funding to do some of this programming, ensuring that, there's informed decision making for both the patients and that the provider has those tools to be able to have that conversation with a Native patient. Next slide. Coco would probably be mad at me if some of you know this, that I use this, but I use this slide because I think she is so passionate about the work she does around traditional tobacco. And again, just talking about representation matters, right? When we're advocating for policy and systems change, that we're uplifting our voices in decision making, that we ensure that American Indian Alaska Natives are represented in policy discussion, advisory boards, and in research, whether we're planning, disseminating, evaluating, research, how are we ensuring that American Indians, Alaska Native are represented? Oftentimes it's a hard balance, right? When you know that we are asking for these people's time and removing them from community to participate in some of these things, but also wanting to ensure that that voice is there. I think oftentimes can be a double-edged sword. Understanding that we need to support and increase data sovereignty for our tribal nations so that they can own and control data that is happening with their people and on their land, that they're driving what research is being conducted and how they can use those results in a way that uplifts the community, that brings, healing and not harm. And so again, being able to see where we want to have access to more up-to-date real-time data in our tribal communities and also to just be included in some of those data points. I will do my best to go through this next section in 2 minutes. So getting to some of the fun resources that we have created at ACAF, how we can promote cultural competency. This is one of our most liked resources. Again, understanding that Indigenous lifeways are prevention and how we use all of those to think about, where we are on that cancer continuum and what are those unique health needs of our Native people, honoring those needs, those traditions, and the strength, and understanding that each of our tribal communities has their own histories, their own strength. Again, I mentioned there are 574 tribal nations across the US. Even a tribe in northern Michigan probably has some differences between, those tribes in the southern part of the state, how we can tailor those interventions so that they are effective, and that they're impactful and that they can be sustainable when working with our tribal communities. And again, just, how we're doing our best to improve some of those health outcomes. And again, using those solutions that are rooted in our community voices and that, we do our best to walk alongside tribal nations when making some of these decisions to improve health outcomes. And I think, again, going back to who we are as Native people, we know that our ancestors have recognized that, our lives are sacred and that we should take care of our bodies, and how we bring all of that into this work that we do is so important. Next slide has two of our resources. One is Check Your Dudu Shiman, which is breast in Ojibwe, kind of understanding, what are some of those risk factors, are things we should be looking for as we think about prevention. And then this resource on the bottom is Lungs Are Important. Nia is sacred. Nia is breath in Lakota. And so we have blank versions of these where clinics can download and print these out and put in their tribal word for breast or breath. And so, how do we bring these tools that are culturally responsive to awareness campaigns, to things that are needed in the community when providers and navigators and even community health workers are wanting to engage with community members to talk about screening, early detection, treatment, and even survivorship? We can go to the next slide because that one kind of looks over some of the same stuff. I talked a lot about traditional foods, right? From colonialism to where we are today with cancer prevention. We have created a couple cookbooks. This one is for breast cancer, and our staff kind of pulled together some pink inspired recipes that are healthy, that promote that traditional diet. Again, how we can use that as a way to reduce cancer risk, but also for cancer survivors as well. One thing that I did with this in a presentation last summer was to have attendees pick one of the recipes and, see if this was something truly feasible at their grocery store that they use and pull prices and, were there things that they would adjust. And it was just a really nice time for folks to share that and they wanted to share that. And so this too is available to download. I know you all are in Michigan, but if you're ever in Minnesota, we have these on hand and would love to welcome you all to our space and hand some of these out. So Beth, I think you need to come visit. Next slide. Again, just more resources, one on heart health within our tribal communities. And then the one on the left is about understanding that, tobacco holds us, carries me, and is the place where it's supposed to be. So again, a resource on traditional tobacco. Next slide, again, just the recap of where we were in conversation with understanding historical trauma, how that has impacted health today, how we can take that information, use data to inform and advocate for policy change, and how we can come from that, cultural lens when working with our Native patients. Next slide. And so, not in conclusion, but as we move forward, wanting to acknowledge that the true impact begins with respect. It continues through partnership and is sustained by tribal leaders. And together we can honor the strength of Native communities and create a future where health equity is a standard and not a goal. So happy to be with all of you today and have this conversation. Kitabi Wobida, thank you.
Miigwech, Melissa, thank you so much. I want to open it up to questions if you have any. Just raise your hand and we will get started here. Or if you just want to drop something in the chat, if you feel more comfortable that way. We did have a request for resources on incorporating traditional practices and resources into your organization. And Laura is posting some links in the chat. And after Laura does that, we will take these same links and put it into our Growing Garden, our website that supports this project. Any questions for Melissa? Catherine, do you want to monitor the chat? Go ahead, Sierra.
Hi, pardon me, guys. I'm driving. I wanted to ask in terms of, because I'd asked about the resources and I guess steps in terms of smudging and things like that. If you're not a member of, the indigenous and you see this opportunity to service those people, is it best practice to inquire, maybe what culturally, and this could be with any community, but what steps would you like me to participate in, or is there a service like smudging, or is there tobacco or something that I can get from you? Is that something that we would have prepared? Because I know that you guys mentioned wanting to source proper tobacco and not just recreational chemically altered. Is there somewhere that we could get that, or is there a way or best practice that you would suggest that we offer something like that? Because I wouldn't want to impede on someone's spiritual practice where I don't belong, but I would want to offer that support so that if that's make that community with me, that they know that I'm, willing to both learn and participate correctly.
Melissa, do you want to answer that?
Say, do you want to answer it? Yeah. I think that's an amazing thing to recognize, right? That this may not be your culture. And I think it's important also to note that all Native people may not practice that way either, right? Again, we think about that removal of so many of our families has created different ways of practicing spirituality. But once getting to know a patient, I think you should be able to have that comfort in asking. But I want to say there probably are resources available that can talk about smudging. And I did see somebody did put in the chat the Good Medicine Keepers. And so I'm going to guess there's something there, but also I'm going to say Intertribal Council of Michigan probably has resources. And I see Beth smiling.
We do. And
Okay.
honestly, I
Not
don't
at all, Beth.
possible for you to have every single thing that someone would need in a healthcare setting, but welcoming their traditions and asking if, and that's something you can ask anyone, right?
Yeah.
Is there a special aspect of your life or culture that you would like to incorporate into your care? Like just that one question kind of breaks the ice and allows individuals to share with you what they would like to incorporate in their care plan. So, Catherine, are there any other questions right now?
I did a breeze through the chat and I didn't see anything that didn't seem to be already addressed or answered. But I will take this time to just say thank you, Melissa. You shared so many great resources, reminders, suggestions, and opportunities for understanding today, and really appreciate. I wrote down a lot of what you shared, but specifically appreciate what you said about health equity. It's not the goal, it should be the standard. And I think that's a big takeaway for me today. So thank you.
Catherine. And again, I have my email, I put my email address at the bottom of that last slide, but I'll put it in the chat. And, folks, feel free to reach out at any point to visit our website. And I know you guys have great resources within your communities as well.
And we have the Hope Growing Garden, which is on the ITC website, and we will send the link out. It will have this recording. It will have the resources discussed. We'll put make sure you have ACAP's website, National Native Network, and a spectrum of resources available to you. And as always, you can reach out to Melissa, myself, Laura Fisher, Dr. Bell. If you have any questions or you would like additional information on this subject, I want to personally extend all of my heart and gratitude to Melissa on this very busy day she had today, and dedicate this session to all cancer survivors and family members who are walking this cancer journey. To receive any continuing education credits, scan this QR code with your phone. Once you do that and you are into the Cloud CME, you have from now until you have quite a while to claim credits. You just have to get in there today and text 65977 to that 844 number. If there are no other questions, we will give you some of your time back. Again, thank you for participating in this learning session, and we look forward to seeing you in May, where we